sit first. Right, brilliant. So, good morning. First of all, I should like to thank the AmCham for the trust in having me participate in the scientific design and drafting and preparation of this conference with Professors Athanasakis and Kyriopoulos. I'd just like to thank you, all of you. I don't think that you can hear these demands and these requests. And I can say that when we were designing this conference, I was rather stressed in keeping the time, because this is a sign of respect to all of you who are here, but also the next speakers whose schedule cannot be overturned because of the fact that we're not keeping the time consigns. We're doing so well that we are early. I've never seen this in my 30 years of experience, and I don't know how to handle it, actually. And I want to share with you this comment, because it's really worth it. Excuse me? Yes, well, I have a lot of things to say, but I can't share them with this audience. Now, right, okay, thank you very much. I really love seeing a full room, a full house. And, well, to the question whether we're ready, there is an answer that is rather macabre that will say, well, we'll see during the autopsy. Now, I don't want to use this. I want to see the glass as half full. I'm an optimistic kind of guy. And the fact that we're discussing these issues, with this agenda, with these people here, with this lineup, as it were, and the participants from different sectors, the market, the academia, the decision makers and the patients, I believe it means that we have taken a first step forward to be more ready. Now, in my experience, well, you can never be ready with health, because whenever you feel you have solved a problem, another 10 spring up. And we usually look at central governments dashing behind the developments because they are rampant. But I have the pleasure and the honor of discussing these issues with all of you following us and watching us with a distinguished colleague, Professor Elias Mossialos, who does honor to our country internationally with his scientific action, with the provision of advice to healthcare systems, with the comparative analysis of healthcare systems and the promotion and highlighting of significant health problems. So we have this one-on-one or one-to-one discussion which is focusing on the future health system challenges and the macroeconomic environment as is constantly being shaped under the pressure of constant developments and challenges, with the question whether we are ready. Now we'll try to give some answers, or rather I will try to extract some answers or extort some answers from the dear professor, some concerns, some thoughts of how we will be slightly more ready. Now, I don't know whether he's already online. Well, your head is marginally there. Please move back. Oh, right, these are instructions to Professor Mossialos. Now we're trying to connect with Professor Mossialos, and yes, we have dear Elias. Good morning, we're very happy to have you with us. I don't know whether you can hear us. I can hear you very well. Can we pump up the volume a bit so that everyone can hear in the room, Mr. Mossialos, Professor? I think it's better now. Now, I made a brief introduction in the topic of our discussion, and we are innovative as a conference, and we're not just on time, we're a bit early on time, and I'm ecstatic, I'm enthused about this. So we have all the time in the world to talk about all these issues, that we can meet all the new challenges. And after saying good morning once again, dear Elias, I would like to raise an issue, raise a subject that you have also done in the public debate, and that has to do with the various crises. We have the climate change, we have immigration flows, conflicts, war conflicts in our neighborhood that overturn our designs and plans with a lot of liquidity or fluidity, which is a potential financial fluidity, and we all remember the recent financial crisis. So how do you see all these things influencing the sector of health internationally, not just through a Greek perspective, but international, on the basis of your experience and all this course you have had, from the comparative evaluation and assessment of healthcare systems you've done. Yes, well, thank you very much, Kyriakos, for this very interesting introduction and question at the same time. These multi-crises affect the environments regarding the implementation of policies, which is politicians internationally in our country refer to the coordinated management of many things that happen at the same time. Now, at the healthcare level, the biggest problem which we will be facing the next years, and we're already facing it, and we see its effects, is the climate crisis. It's not just climate change, it's climate crisis that creates a lot of problems in the healthcare system. And the Australians are already experiencing it in areas of California and the United States, see it where we have significant impact with the wildfires there, and with also other environmental crisis issues. And the United States is a country that contributes greatly, impacts rather negatively alongside China and other countries in these climate crisis phenomena. So were these phenomena of climate crisis to deteriorate, we need to expect healthcare offers in the non-communicable diseases, but also the communicable ones. Primarily the respiratory diseases will increase very much, CVDs, but also some forms of cancer. So we understand and realize that if we have these effects, these impacts, there will be a tremendous pressure on the healthcare systems, and their resilience will be put to the test. At the same time, climate crisis will create problems to many countries in the world. We already see the immigration problems in our area and the pressures that Europe is under. But what we see is an immigration problem in Europe, in our country, in Italy, and some other southern countries. And the reactions we have in the northern countries that can no longer accept any more immigrants is the tip of the iceberg. Because the big immigration flows will not be those towards Europe. They will be from the regions of the non-developed countries or the low and medium income countries to the metropolis of these countries, or the large cities, the large urbanization that is expected in the next 20 to 30 years. This means that we will see massive inflows in countries like India, China, Pakistan, Bangladesh. And I'm talking about huge population-wise countries, Indonesia, Bangladesh, and they have over 200 million people. I'm talking about China and India, but there are other countries as well. We'll see this in Nigeria, that is exceeding 200 million, Ethiopia as well, resulting in the development of large megacities with a population over 10 million euros. So these will multiply, and the question is, how will they multiply? Obviously, with anarchy in urbanism, without health and sanitation systems, without sanitation systems that will be combined with this influx of populations, with many immigrants living in favelas, 10 to 15 in the same room, 10 to 15 people, and these are not phenomena that we haven't experienced in the past. Mind you, when the immigrants went to the United States early in the previous century, they had to stay 10 or 15 people in the same room in the United States, particularly in New York and the coasts that were nearer Europe. Now this will create explosive conditions, I would say, for the creation of the next pandemic. So we move from the climate crisis to the immigration problem, and now I'm trying to see whether and to what extent we are prepared to have the coexistence of people, animals, and unsanitary conditions that will create an explosive mix that may have the mutation of viruses that may pass from animals to people, the zoonosis, and see a big pandemic that we're not prepared for. It's the X factor that we call it. It's the unknown factor, the next unknown pandemic, which we will have to discuss how to deal with. Now, these are the big problems. I have more. Okay, these are the ones that will influence the healthcare systems, and the Greek healthcare system in particular is the demographic development, as it were. And here, the evaluations and assessments vary. Not all scientists internationally agree. There are assessments and evaluations from the UN that the demographic boom will continue, but there are the Society of Health Metrics and Evaluation of the University of Seattle that has many problems, one of them saying that there is going to be a reduction of the population in the next 50 to 60 years. But based on all the demographic evaluations, regardless of who does it, there will be a significant reduction of the population in our country and a significant negative impact with many of our compatriots who will be over the age of 70 to 75, a smaller workforce, which means that there will be fewer people in the job market to support the pensioners, and our fellow citizens who will have more comorbidities, being more elderly. So this is a big challenge for the Greek productive model, the Greek innovation model that our country will have to acquire. It's a country without innovation. With today's productive model with small added values, it will have huge problems to deal with the cost of medical care, which will increase. No one can expect that with these developments the healthcare systems will remain at the current expenditure levels. It will definitely rise. We can see this happening every year. So unavoidably this will happen to Greece as well. The question is, who will pay for these increases? Now we have other phenomena, but microbial resistance. Because unless there are new antibiotics in the next 15 years, I would say, the impact will be terrifying. Again, there are assessments that we will have approximately 35 million deaths in the next 10 years without the existence of new antibiotics worldwide. But also a reduction of the average life expectancy by 2 years by 2035 worldwide. We have over 20 years in the 20th century because of the antibiotics, and primarily due to the discovery of penicillin by Fleming. So the gain we had and the profit we had due to the antibiotics may lose it unless we have new antibiotics and we have an increase in microbial resistance in the next 10 to 15 years. Now, thank you very much. So we're talking about a cocktail of socioeconomic factors and purely health ones. I've seen what you've written about the burden on disease. Microbial resistance is one such big threat for public health. But you made a reference to a potential risk of a future pandemic. What did the previous experience teach us? Did you see us developing some reflexes internationally with the contribution of international organizations? And I will make a two-pronged question. If we learn something from the pandemic, and whether the existing international system and the role played by international organizations is enough to shield us more. Let's start from the latter, the role of international organizations, because it's particularly crucial. If there's a pandemic in the next few years, I'm not talking about the here and now, but in the next 5 or 10 years, the international architecture of health response is adequate. What we see is that there's a fragmentation. We were talking about the WHO in the past. Now, the World Health Organization does not have the capacity to intervene in the member states. It acts in an advisory capacity, and it can offer technical assistance. It's not like the European Commission that can, if the member states agree, issue regulations, like the regulation they just issued on AI, which must be implemented. It is mandatory, it's obligatory for all member states. Okay, with the WHO, we have guidelines, which, if the countries want, may adopt it. If not, they do not. And we do not have a global system that will allow the member states of the UN countries to declare problems that have to do with communicable diseases. And the onset of a new pandemic. In China, we were lucky that a doctor was found to speak openly, and we know that he died of COVID-19, who dared speak. Rather late, in my opinion, but the people couldn't speak there given the Chinese regime. And at the same time, Chinese scientists decoded the virus genome and gave it freely to the entire scientific community. Now, I don't know whether this will happen next year in another regime or in a similar regime, whether we will be this fortunate, some people to dare speak on time, or scientists and scientific institution and organization in a country in the future may be able to speak freely and share the data. So we have something that needs a radical change, and I don't know whether all the countries will agree, because we know that the majority of the countries at the time worldwide is not governed by democratic regimes or regimes which would like to share data even in terms of health, which is of low political priority. Okay, as compared to other political priorities that exist at the level of the UN, we talked about the war conflicts in the area. In tandem with the WHO, with other organizations, the World Bank, which invests at the moment significant amounts in dealing with the next pandemic. We have the pandemic fund, which invests in medium and lower income countries. At the same time, we have the SETI, which is the preparedness and innovation, which is in London but also in Norway. We have a big supranational attempt, an effort that is supported by the British and the Norwegians, aiming at having the next vaccine within 100 days in case of the next pandemic, rather than within 8 or 9 months, as was the case with the previous pandemic. But at the same time, we have organizations that coexist with the WHO. It is Gavi for the vaccines, and the UNH that actually has to deal with AIDS-related phenomena. And these are great examples for the WHO, and it is part of the UNO. Why am I mentioning all these organizations? Because there is a fragmentation worldwide, and not necessarily a synergy. Whereas the European Commission is taking rampant steps forward. We have the Health Emergency and Preparedness Authority at the level of Europe, which is a strategic choice and decision that is very strategic in terms of Europe, but we do not visibly see what this means. They said that they would focus on communicable diseases and the production of new vaccines, and we're trying to see what will happen next. We have some steps forward to better coordinate the European Centre for Treating Diseases, the ACDC, and at the same time, do we need a centre only for European countries, or should we have a more expansive in a positive way policy and include the entire European region of the WHO, which undoubtedly raises difficult political questions, which you raised as well. Will Russia be part of this construct, dealing a common problem at the European level, or we will have different treatments? And it sets the stability and flexibility of the world system to the test by these war conflicts, but also the US elections. Now, should the negative, in my opinion, happen if President Trump would be re-elected, they would withdraw the United States from the WHO because he didn't like how the WHO handled the previous pandemic, but also because he believes that the United States pay too much to maintain this organization. He believes that this is not money well spent for the US. So imagine a cocktail in which the US leave, Russia might leave as well as a result of the US leaving, or Russia remaining, because they consider that the US leaving will give them a strategic advantage and an edge within a very important international organization, and so on and so forth. I mean, things are not clear, are not in focus. I hope that we will have political developments in the US that will not threaten the existence of the WHO, but we need to discuss very openly what sort of international interventions and organizations we want. And if something we learn from the pandemic is that very simple things must happen. One of them is epidemiological surveillance. We need epidemiological surveillance and awareness, same as with the flu. Each year we have a different vaccine for the flu and different vaccines in different areas of the planet. It's not the same vaccine in Europe with the US or China because we have different mutations. How do we know that? Because there are 36 centers with the WHO the world over that examine the mutations of the flu virus worldwide. Now we need similar interventions and fundings, primarily in low and medium income countries, because it is more likely to have problems from there with the next pandemic, where an epidemiological surveillance of entire families of viruses will be performed. We can't target specific ones. We need to see virus families and to see potential mutations in these virus families. How much will this cost? Well, it will cost several billion euros. It is approximately 10 to 30 billion euros per year to have this surveillance. And the pandemic cost the global community 20 to 30 trillion in the first 2 years. It has a huge economic impact. So did we learn something? I would say no. I would say no, because we thought that we overcame this problem. And sometimes applied politics, and policy is here and now, rather the medium-term, long-term policies, the benefits of which can be attributed to other politicians, not those who came up with the policies. So this is the drama of policies and politics. Okay, people benefit from the politics of their predecessors, or also pay the slab for the politics. But we need to have a global consensus of these things. Okay, I mean, if we will have a public or a private healthcare system where we have ideological extensions there. Maybe because consensus is not a very easy thing, maybe a more binding supranational framework and international organizations may be something that is imposed. And we said something that one of the next bets is to have vaccines available faster. But what we must gain is the will of the citizens to be vaccinated, because there was a huge battle that was fought for epidemiological surveillance and also the value of vaccination against COVID-19, but there were values that voiced in a different way in order for many of our fellow citizens delaying their vaccinations with tragic consequences. And we saw this in many countries. And over the pond, we saw another management that was rather weird. The Chinese virus, the Kung flu and everything, it was epidemiological. They did not help utilize all these scientific advances. I will agree that Europe is slightly ahead, but the job will be done if we have a more binding supranational framework. And the same goes for artificial intelligence, to move on to the next topic, which you already talked about. We have a new player in the healthcare system. Are we leveraging it sufficiently or to the best extent? At the same time, what are the risks? We have a decision-making process based on an algorithm that a source of data has a problem with the algorithm itself. And the doctor is led to a decision, and this is the personal level, who is responsible? The Indian who created the algorithm, the IT guy, the one with the data entry, the one who collects data, or the doctor who makes the decision? And these are things that will be of concern. And here we can talk about our country to see whether we're ready to incorporate all these things in the operation of the system. If we start from our country, I think that it was October the 19th, when we announced the National Committee on AI. It's approximately 1 year since this committee was announced. We should have already seen its findings report. Okay, Kyriakos. A year is too long when we're talking about rampant developments. It should have been a permanent committee on AI, which should have had issued a first initial findings report. Yes, because this is something that changes every month, I would say. So we would expect an initial finding of this committee on where our country is, the sufficiency of our country and what must be done, and then to renew and update these findings with individual findings. And this is important. In the National Committee on AI, there is no representative from the healthcare sector. It is a sector that has the most data, worldwide. The most data we have are in the health sector. This does not mean that they will always be in the health sector, but in health we gather more data than other sectors. And we have a lot more processes and procedures. Millions of citizens use healthcare systems, and in our country, and billions the world over. So we gather a lot of data. Now, who creates these algorithms is crucial. Who creates these algorithms and what systems they use is very important, because there we can have systems that might affect political decisions towards a specific direction, create inequalities, exclude specific benefits, citizens from the benefits of AI, because AI can be used for the allocation of resources, for the changes that may be made, for the applied policy. Information gathered may lead to political decisions that might increase inequalities, either at the local or the global level. So control of how one structures AI is crucial, but therein lies a difficulty. Compared to another global problem, which is nuclear power, and we are all thinking about what will happen with the uncontrollable use of this sort of power, which is the cleanest one. But the problem with nuclear energy, which is why many countries are afraid of implementing it and are afraid of other countries implementing it, is the irrational or uncontrolled use, not for the production of clean energy, but for weaponizing it or for affecting war conflicts. But nuclear powers are not controlled by the private sector. Nuclear power is controlled by the states. So here we have interstate agreements, and there is a global organization for the management of atomic energy, which is headquartered in Vienna, and there are interstate agreements on which countries can have atomic energy, nuclear energy, and not all countries are allowed. Some of them acquired it illegally, so there are some exceptions to this rule. But artificial intelligence is not controlled by the pharmaceutical industry, and it is highly regulated. So we have the FDA, EMA, we have regulatory organizations. There is no single global regulatory effort, but we have the International Conference on Harmonization, where we have the harmonization of all these areas at the level of pharmaceutical industry. At the level of AI, we don't have a global framework, you see. And we are at initial levels, and there is a global competition at the moment on who will have the upper hand. Will it be China? Will it be the US? Will it be a multi-fragmented Europe which is no longer politically undivided as it was a few years ago? I mean, at the moment, we can't talk about a single political framework in Europe, or for a will of a greater political unification, as was the case when we had the law in the previous decades. Now the will is to move to more national policies. So it was very good when you raised the question on how to control the algorithms and whether at the end of the day it will be the doctors who make the decisions or not. But the doctors, all the HCPs, the healthcare professionals, are the ones who need to pose and raise the correct questions. Because if you can't pose a correct question and you don't know how to explain the complexity of the information you receive from AI, then obviously you cannot reach complex or composite conclusions. Do we have AI in academic studies, in the medical schools and everything? Well, I have a question about this. I mean, I kept this best for last. I mean, for instance, in pharmaceutical schools, I see that there are no key pharmacy management classes. And this is the ABCs. There is no artificial intelligence there. There is no statistics in epidemiology and medicine. In medicine that I started a few years ago, several years ago, it was something that, well, we needed just to pass. I don't know whether this mentality has changed, but it was a necessary evil, that we needed to pass Mr. Trigopoulos' class and to have some epidemiology and statistics, but we wanted to pass other classes. We're very excited by surgery, for instance, or some internist specialties rather than epidemiology and statistics. Now, all doctors and HCPs in the future must be specialists in biostatistics, epidemiology and AI, because it will go hand in hand with medical knowledge. Unless you know good medicine, you will not be able to handle AI. Suppose the algorithms are correct. Let's say that everything will happen in the best possible way. Unless you raise and pose the appropriate questions, AI will not give you the right answers. Unless you're able to analyze the data you receive from AI, you might have frivolous answers if you make frivolous questions, and you will not resolve the questions. Now, let's be more realistic. The problems in medicine now are not single dimension. It's not the 1960s where 5 or 6% were over the age of 65 and most people had 1 or 2 diseases each. Things were much more easy back then. At the level of primary health care for family doctors and general doctors, they had to deal with patients with 1 or 2 problems. We all know that 70% of the patients who are admitted to hospitals have comorbidities. And here we have questions about the hospital model and the non-synergy of specialties in hospitals. And at the primary health level, how much we deal with these cases, simply put, in clinics where we have a single doctor. I mean, there aren't many countries where we have a single doctor at the primary health care. There's a synergy of many specialties in developed countries in the planet. So here we have these problems. In conditions of comorbidity, can AI give sufficient responses? A complex or complicated problem where you have a cocktail of diseases, you expect artificial intelligence to give you an answer, which might be given to you by synergies of specialties with very experienced doctors. So for easy things, AI might be able to give some answers. I mean, if someone has only diabetes mellitus, or an inguinal hernia or something, and they may have thought something that the doctors haven't been specialized in these techniques. And even if they receive the information from the AI and have not performed the surgery, they will not be able to do this either. So it's a combination of AI with the knowledge that AI can give us and the experience in simple medical problems at this phase. I don't know how it will develop, and it will definitely develop and grow in the next decades, and it may be able to resolve more complex medical problems. However, without the synergy of doctors, I see this as very unlikely of happening, without the experience of medical acts. But I don't think it's unlikely to happen in some medical specialties. I mean, radiology, for instance, it will happen much faster. The Wellcome Trust now has the top 2 billion images. It accumulates 2 billion images. It will be 10 billion images or 20 billion images, which means that AI will have a great adequacy of processing radiological imaging. It does not mean that radiologists will be out of business, but it will change their profession. They will become more interventional. At the diagnostic level, in the more complex ways, AI will not be sufficient. In anatomical radiology, will have great use of AI because it's imaging again. Wherever we have imaging, AI will be better. Where we have a more complex approach with comorbidities, it will be more ancillary, I would say, for the other doctors and the other HCPs. It will not be the absolute solution to the problem. And of course, big applications at the level of pharmacology. I mean, the scanning we will have through AI for the chemical substances and the possibility of chemical substance we have of dealing with the disease will save us a lot of time, and this is what the pharmaceutical industry already does. But there is no concern there because this is within a controlled environment. The pharmaceutical industry, as I said before, is an exceptionally controlled industry. We have regulatory authorities that will allow the entry of a drug into the market. We have additional medical assessment and the health technology assessment. We have funding mechanisms, whether we will pay or not for a new drug, which we do not have at the level of AI. We're lagging behind there. So artificial intelligence at the level of pharmaceutical industry within a controlled environment is not of concern. It is a very auspicious thing to happen. It's problematic is in a non-controlled environment. Yes, and truth be told, it will never replace medical intervention and judgment. It will assist it. But I share your concerns because we're talking about an environment that is not sufficiently regulated. In the single European health area, we have some added value. I heard about an experience exchange program, 60 million images on cancer, which means that it will transform this individual information in each patient into wider knowledge, which means more valid diagnosis and more safe treatment choices. But this is the big challenge. We will expect and wait for the work of the committee to be expressed more vividly and more updated, and to make this into a decision-making process. Now, in general, you see the problems and the discussion, the debate around the healthcare problems, and we see that the ministry is trying to resolve some problems of staffing, equipment, and so with targeted actions. We have some building upgrade programs running. But is it what we really need at the moment? There are no reform or innovative things, and they're not very popular because there's not a lot of ribbon cutting there, and it does not bring you in before the press of cutting the ribbon of a new computer, of a new CT scanner. It might not be perceived by society. So how do you see our country? Problems are solved in a targeted way, and we try to bring more doctors to staff areas. Is this enough? Is there room, political, social and financial, for a structural reform that we all say is needed by the health sector? Well, Kyriakos, these firefighting or patchwork solutions, let's take a simple example. The doctors, the new doctors, the residents, what was more important in terms of health policy? I'm not talking about medical, the residents or the interns. What we are trying to have, it's a global paradox with interns. There was no other country in the world. I'm not talking about the doctors who already have a specialty and may have a private practice. You might remember that it was I who talked to Alekos Papadopoulos when he was the then Doctor of Health, the afternoon offices and the doctor's offices in the clinics. They did not happen that much, and they should have done with other than the general practitioners or the internists, and we would have had more experience. And for surgeries within the public sector, outside normal business hours. But now in Greece, the critical problem with interns and residents, was it for them to have a private practice or to focus on how to receive proper education so that we can have good doctors? In my opinion, the most important thing that could be done in the health system is an improvement in human resources. We need to have good human resources, which clearly includes financial incentives, because unless you have serious financial incentives in the healthcare system, you cannot keep the good doctors within the private healthcare system. They will go into the private healthcare system or go into other countries, as many Greek doctors do within the EU and outside the EU, given that there is now a lack of approximately 1 million HCPs in the EU. Not just doctors, but also nurses and other HCPs. But I talked about the interns and the residents because it is a cause of great concern, and it's painful for me, for someone who's been working for over 30 years on the national healthcare system. This year, it's 30 years since the experts' report that was created by Andreas Papandreou and Dimitris Kremastinos in 1994, and I was the coordinator, which was presided over by Brian Abel-Smith, my professor, with the participation of many experts from Sweden, the Netherlands, Canada, the UK, the elite at the time of health and health policy. It wasn't just politicians, it was also doctors. Okay, their points of reference. Okay, it was 30 years ago, and I see in my country not choosing to have a plan to reform medical education, not have a plan on how the young doctors who enter into the medical system to acquire serious knowledge do not focus on what they learn. We want a good ENT, a good surgeon, or a good endocrinologist, but focusing on the afternoon profession. Let's do this as well for the interns and the specialists, but we could find this money for something as important as the HCP sector. But you start from the curriculum first, and what sort of doctors you want the health system churn out, because you receive your specialty in the public hospitals. Let's not forget that. And in most public hospitals in our country, we don't have organized clinics. There are doctors or teams of doctors and associates. There's no sense of clinic. Okay. There's a Greek hospital in the private country with 500 cardiologists. They're all directors of cardiology. They cannot give a specialty to a doctor. It does not mean that they are not proper cardiologists, but the training is not appropriate. They may be perfect doctors with perfect medicine, but unless you have an organized clinic with organized curriculum, that is very difficult for the private sector to be given to a private hospital, this is lack of hours from a profitable profession. I mean, the public system will accept the loss of productivity, but also the university system that needs to teach all modern developments to young doctors, young pharmacists, young dentists, and young nurses. So what we need is, at the same time, with these focused and targeted solutions, which you can't not do, when you have a problem, the health ministers and the associates need to resolve these problems. So unless we say that we need to come up with huge reform solutions and without watching at the problem we have with the lack of an ambulance, the lack of a GP or an anesthesiologist or a surgeon, then we will fail. Politics is to resolve immediate problems as well, not just the medium-term and the long-term ones, but unless they focus on what is substantial and essential at times, such as education, then we need to wonder what it is we should be doing differently. I don't want to talk any further at the moment, because I have a motto. When there's a leadership in the Ministry of Health and a new leadership, I want to give them more than 1 year to show us what they want to do. And it's what's appropriate. Okay, this is the 6th year of government of a single political party, but we do know that the Ministry of Health has undergone many changes. And it's a ministry that's not the most pleasant one, and I'm trying to be as fair as I can, saying that the Ministry of Macedonia and Thrace does not the same gravitas or difficulty or other ministries as compared to the Ministry of Health that works 24/7, 365 days a year. Millions of citizens use these services 24 hours a day in many different areas. We take the Ministry of Education, which is another of the utmost importance for the future of our country. Well, the educational system does not work 24/7 or 365 days. It works half a year. So there is still room for the political leadership of the Ministry of Education, time limits I say, to draft plans more easily than the Ministry of Health when they need to solve everyday problems. When you need to solve everyday problems, you need to find some time at the governance level, and the administrative level, and the local level of the Ministry of Health, and to think about these bigger strategic choices that, as I say, have to do with the change of the epidemiological model, which is much more adverse in our country than others. I mean, Greece and Spain are all the same. Spain has immigration policy from Latin America, so it has a big reservoir receiving from there. So there was an increase population over the past 20 years. It was Spain, so it will not have this aging population phenomenon. Without such a burden demographic indicator, which we will have, or the pressures of on our financial economic system. So this demographic aging, which is ante portas, it is before our doors. It says a lot of things here, and it needs different things than personal doctors, different systems of hospital healthcare, from the fragmentation, and it needs a lot of frank and earnest discussion with the Greek society. And we need to have several hospitals at 20, 30 kilometers, or much bigger hospitals with much better human resources, with more safety and security for the patients. And this is not something you can do here and now. It requires a lot of debate, open debate with societies. They do not presuppose and require something like I go and close down a hospital, or to merge hospitals, or to fire people and reduce cost. It's not a matter of shrinking the expenditure, it's on when you're safer where you live. You're safer when you have a very small hospital and another small hospital and another small hospital right next to it, or are you more safe when you have stronger healthcare structures and units? In this sense, this dialogue and debate with the Greek society must happen at some point, within a framework of political consensus rather than a conflict, which means that the conflicts must be rather milder, if I may. The confrontational level I don't think is conducive to a good healthcare system. I mean, Greece is a confrontational country, and its political system is a confrontational one, but herein lies a big opportunity. The government has no opposition. This is a government that does not have any labor unions against it. I've never seen such political gap at the level of opposition, but even unions, labor unions. I mean, whenever there was strong opposition, there were strong labor unions. So the responsibility of the government is disproportionately large as compared to the previous government, and it has a lot of European support. Now, this is all I wanted to say at this point, saying also, but we need to be very careful when we're talking about the healthcare sector, because it's the most flammable or explosive ones. Okay, most politicians do not want to go there because it has problems that create more problems. It is the most difficult ministry there is. So our criticism should be within the confines that it will help the leadership, but at the same time we need to voice our concerns. The political leadership of the ministry should not rely on the fact that there is no opposition and there are no labor unions, and because 41% of the people voted them, that they shouldn't hear opposing voices of what should happen in their country. I think that was clear. Yes, I will agree that any question that is raised to public debate is done to help rather than to cause problems. So let's find the proper mix of immediate responses and long-term ones. We should not underestimate these interventions. They are necessary for everyday citizens and in order to deal with the hic et nunc of the here and now. It's the medium term and the long term we need to talk about. these things are so complex and composite that unless we circle them around, we need a pluralism, okay? The public regulation is the most important thing, because if we see what the citizens think is, I mean, they have a stress, an insecurity and a risk when they deal with health-related systems issues. And 80% of the populations have systematic use of the healthcare system. Now, in conclusion, apart from this interest and everything, is the over-regulation. We have a 400-page long regulatory system that regulates universities, so the higher education is over-regulated as a whole. It is always brilliant to talk with you, Elias Mossialos. I can talk with Mr. Mossialos for hours, because discussion makes us wiser. We take ideas, we take experience, and a supranational approach, a fresh one, exactly like dialogue must be. Let's hope that political dialogue will be the same thing, well documented, in an effort not to dispute and to question or to have a reflective reaction. And I don't want to remind everyone of what happened during the pandemic, but to be fertile and productive. Because there are no ministers who become ministers to fail, nor do we want for a health minister to fail, because it has a huge political refund and social refund. So thank you very much for the pleasure and honor of this discussion, personally and as a whole. Thank you very much and enjoy. Thank you. Good morning.